All right, it's Dr. Lisa L. Campbell. I am back with your week 5 lecture, part 2, where we are focusing on the digestive system. And this chapter is a little longer, so let's dig in. Objectives for this week. So it's or for this chapter, it's all about the digestive system, right? So knowing the key terms, abbreviations, anatomy, common procedures, selecting the procedures, and then ultimately coding from case studies. So, the digestive system is also known as the alimentary canal. And you know about this system because you have it, right? It includes functions such as allowing us to take in nourishment, food, breaking down the food during digestion, absorbing those nutrients that we need, and then eliminating waste products. The digestive system has several major organs, and as you know from previous chapters, we always start at the top and go all the way down to the body, to the bottom within that particular system. And so here we start with the lips and mouth and go all the way down to the anus. As you are thinking about preparing for the CCS or CCSP exams, just keep in mind that you got to know your anatomy, right? So let's talk about abbreviations. These are always located in the beginning of the textbook. These abbreviations apply to procedures that you're going to see for this system. Now that I just showed you the different organs that are on the digestive system. So I talked about the lips all the way down to the anus. But with the digestive system, you have additional structures. I guess they call them, I'm not an anatomy teacher, but I guess they call them like accessory structures. So liver, biliary tract, pancreas, abdomen, peritoneum, and then the omentum are additional structures that are coded over here. All right, so on to the lips, top down approach. So in this particular subsection, it begins. So for lips, make sure when you're in this surgery section, you got the right procedure and the right body part. So this particular section with lips begins with codes for excision procedures. And a term that you should be familiar with is the vermilion, and that is the pinkish border of the lips. And so the codes that are in this family are going to reflect procedures performed on the lips. So you see biopsies, you see repairs, also known as chilioplasty, and then you also see different types of deformities that need to be corrected. Codes are available there as well. The vestibule of the mouth, the mucosal tissue, so your cheeks, and the submucosal below tissue of the lips and cheeks comprise the vestibule of the mouth. And keep in mind that the teeth and the alveolar process are not a part of the vestibule. So there are some notes that appear for codes 40804 and 40805 that identify the differences between the codes. Um, these codes are for removal of an embedded foreign body from that part of the mouth. And so documentation must record um, the requirements for those two codes. So you want to take a look at those codes. So we also have codes for incision and drainage. And I know what you're thinking. We saw incision and drainage in the integumentary system. Yes, but remember, we are we are inside of this organ as opposed to on the outside of it. We also have codes in this area for so when we talk about incision and drainage, we're still talking about abscesses, cysts, hematoma, right? Same type of issue, but just inside the organ instead of out of the organ. All right, then we have excision and destruction of lesions. And then watch out for words like simple and complex, because that's one of the differentiating factors. And then you have codes for repair. And same thing, you need to know if the procedure was simple or complex, but you also need to know if it was done bilaterally or unilaterally. And as you continue to listen to these lectures, one of the things that I would highly recommend that you do, you know what I'm going to say, bubble, bubble your CPT manual and highlight, because it definitely helps to for identifying the codes easier. All right, so on to the tongue and the floor of the mouth. Terminology over here is going to be very important. Terms such as lingual, which refers to the tongue. And at times, the physician may say sublingual area, that's underneath the tongue. So, like some medications are sublingual. All right. Then you also have over here the frenum. And the frenum is it's just a connection. That's the easiest way I can remember. All right. So procedures that are incision and excision are what you are going to see first. You will see more incision and drainage codes over here. Yes, and it's incision and drainage of an abscess, cyst, or hematoma, but it's about where these abscess, cyst, or hematoma are. These codes can be differentiated by the area of the tongue or the floor of the mouth treated. So be very careful. As it relates to repair codes, um, they are differentiated by the size of the laceration repaired as well as the actual site. All right, next up we have dental alveolar. So the alveolus is the socket where the tooth sits. And of course, abscess, cyst, and hematoma. You got some incision and drainage codes for this particular body part as well. I guess you're seeing a trend. And as it relates to excisions and destructions, these codes have some specific terms that are referenced in the index to locate the procedures. So, gingivectomy, operectomy, excision, then lesion, then gum, alveolectomy, and then destruction, lesion, and then gum. So remember how we talked about there are four primary classes of main terms. There could be more than one way to get to a particular procedure. Next up is the palate and the uvula. The palate is more commonly called the roof of the mouth. The uvula is located in the posterior border of the soft palate. And you can recognize the uvula by the fact that it's a small cone shaped mass of flesh that hangs from the soft palate. Um, if you take out your set, not right now, but if you take your cell phone, you could actually see the uvula. So there's only one incision code in this particular range, and it's for drainage of abscess, palate, uvula. And then you have a bunch of repair codes. They are differentiated. I'm sorry, before I get to that, with the codes I just mentioned, they are organized based upon whether or not a closure was completed. And if a closure was completed, you have to figure out if it was simple or complex, right? So You're seeing some of the same trends with regards to the procedure. Oh, I did want to mention that there are repair of laceration of the palate, and same thing. Is it complex or not? Right. But also the length of the repair over here as well. Salivary glands and ducts. So salivary glands secrete saliva, which aids which contains an enzyme that aid in digestion. And there are actually three pairs of salivary glands. You have the parotid glands, and those are located in the front of each ear. The sublingual glands, of course, underneath the tongue. And then that third set is the submandibular glands, which are located on the floor of the mouth. So, this particular family of codes does begin with incisions. And of course, you got some abscess. And the funny thing about the abscess codes, they are organized based on the pairs. What pairs? Parotid, submaxillary, or sublingual. And then, of course, we have some repair codes. So there are plastic repair and diversion codes of the salivary glands in that particular area. All righty. Next up, the pharynx, the adenoids, and the tonsils. So the pharynx is a passageway that connects the oral cavity to the esophagus for the digestive system, but it also is shared with the respiratory system because it connects the larynx to the respiratory system. So I always remember PLT. PLT, pharynx, larynx, and trachea. All right. So I talked about the pharynx. Oh, adenoids. So adenoids are one of three sets of tonsils. Adenoids are also referred to as the nasopharyngeal tonsils. So there's three pairs of tonsils: the nasopharyngeal tonsils, that's also the adenoids; the lingual tonsils, which are at the base of the tongue on the posterior surface, and then the palatine tonsils, which are the pair that are most commonly referred to as the tonsils. One thing about the human body, it is definitely um, complex. It has a lot of stuff going on. In this particular code family, you're going to see the same stuff: incision, excision, destruction, repair, and then other procedures. All right, on to the esophagus. The esophagus. So, over on the esophagus. Oh, let me tell you what the esophagus is. It's a muscular structure that moves food from the pharynx to the stomach. And the codes that you're going to see over here literally is following what you've seen so far, right? So you have incisions, you have excisions, and um, with excision procedures, what you'll want to note is codes are determined by how much of the esophagus is removed. So you got to pay attention to that in the operative report. And over in the esophagus, you also have some endoscopic procedures. And what you're going to continue to see in the surgery section is that the name of the scope is literally going to change based on that body part. Okay, so couple of things to note here. We have endoscopic procedures that are diagnostic or surgical. You also want to pay close attention to situations where we start off as an endoscopic procedure, but then the procedure is converted to an open procedure. There are some notes over in this area that you want to pay attention to. because it will impact correct code assignment. Esophagus, other procedures, you're going to see repairs. The approach is going to matter when we're talking about repairs. But then you are also going to see another type of scope procedure, which is called laparoscopic. And just remember, the name of the scope is basically telling you where they are going. Okay. Um, Other things that you're going to see over here, ligation codes, closure of like a fistula, suture of an esophageal wound or injury. You also are going to see manipulation codes. Manipulation is this maneuver by hand to treat or perform therapy. Remember how with the musculoskeletal system, you saw that they could do a closed fracture by they could repair the closed fracture by manipulating it. So that is pretty much what you see over there. um I think I mentioned dilation, but did I tell what it was? I don't know. So dilation is when they are expanding or stretching a particular area. And so you will see that noted in the codes as well. And then ligation is a procedure that ties or binds something together. And they can use cat gut, cotton wire, or silk to accomplish that procedure. All right, now we're going on over to the stomach. I feel like I need a sip of my tea. All right, so the stomach is a pouch like structure that aids in the breakdown and digestion of food. So, breakdown and digestion of food. We have procedures on the stomach that are grouped by incision, excision, laparoscopy, introduction, bariatric surgery, and then other procedures. So, as it relates to stomach incisions, you're going to see gastrostomy, otomy, making an incision. Here, these codes are differentiated based upon what they are doing. Are they just looking around? Are they repairing? Are they dilating and inserting a prosthesis? Pay close attention to what is actually happening with that procedure. Then we have stomach excision. And over here, um, you have biopsy. And of course, if you're coding the biopsy stomach. Now, the cool thing about CPT, in some cases, you can use the body part. So you might can go to biopsy stomach. I personally, and this is just a personal preference, when I'm coding the procedure on a body part, I tend to want to go to the body part first and um then the procedure. And that's literally because I don't want to see the other body parts. All right. So biopsy, excision, gastrectomy, vagotomy. A vagotomy is cutting of the vagus nerve with the intent of reducing acid secretions. All right, guys, we're like halfway through with this digestive system. Laparoscopy, stomach. So we're talking about a scope going into the stomach. And here you're going to see a set of codes to report gastric bypass surgery. And gastric bypass surgery is performed by dividing the small bowel with the anastomosis to the proximal stomach to bypass the major portion of the stomach. And patients who have different classes of obesity will be indicated for this type of surgery. In this particular area, you also have other types of laparoscopic procedures, and they are divided based upon what happens at the end of the surgery, right? So, do they implant a neurostimulator device? Are they transecting the vagus nerve? Um, are they making an artificial opening to the stomach? Just to name a few of the procedures. All right, stomach introduction here. This is where they are introducing or changing a gastric or nasogastric tubes. There are some notes in this area that you definitely want to check out. All right, code 43762 is a code for replacement of a gastrotomy tube, percutaneous. And notice that this particular code does not require revision of the gastrostomy tract. So you want to review the notes that are by 43762 and 43763. And I'm going to just continue on. All right, stomach, bariatric surgery. So, first thing you should know, and probably most people know this today, 2025, there are different types of bariatric surgery. So, there are procedures using like a lap band or a port. These codes are differentiated by the components of the procedure completed in relation to the gastric restrictive device, right? So these components include placement of an adjustable gastric band, which I don't think we see that often. Revision of an adjustable gastric band and then removing it. So the lap band procedure, I'm gonna have to Google myself because I'm interested in knowing how often that's done today. There were some complications with those lap bands. So today, I think you see more of the gastric sleeve, you see the gastric bypass, duodenal switch, right? You see those types of procedures. All right, on to the intestine, except the rectum. The intestine is a membranous tube that begins at the pyloric opening of the stomach and ends at the anus. And the intestine is divided into the small and large intestine. The small intestine begins at the pyloric sphincter and moves through the DJI, that's how I remember them, duodenum, jejunum, and ileum, and the ileocecal sphincter. It's about 20 feet long and encompasses most of the abdominal cavity. So most of the nutrient absorption and digestive process actually happens in the small intestine before waste is moved into the large intestine. The large intestine begins at the cecum and moves to the colon, rectum, and anus. So, what does the large intestine do? It picks up, it further breaks down the food and holds it until it can be further broken down and expelled out of the body. It should also be noted that liquid is absorbed in both the large and small intestine. The largest part of the large intestine, I know you know this, is the colon. All right, and the colon is made up of four parts. All right, so this is not anatomy class. All right, so here are the four sections of the colon: the ascending, the transverse. If you look at the picture in the textbook, descending and colon, you'll see how these procedures are anatomically located. So, coding for procedures on the colon is organized into incision, excision, laparoscopy, enterostomy, endoscopy, introduction, repair, and then other procedures. So incision, you're going to see procedures such as enterolysis. Lysis is freeing up something, and in this case, intestinal adhesions. Duodenotomy, otomy, we're making an incision into the duodenum. Enterotomy, otomy, an incision into the intestine. And those particular codes for the enterotomy are divided based upon the reason for the procedure. All right, codes for excisions completed on the intestines. Here, one word you're going to see quite frequently is the anastomosis. And this is a process of surgically connecting two structures that are usually hollow tubular parts. And an example of a tubular body part is the intestine. All right, so over in this area, you see um, biopsy codes, you see incision, you see resection, and of course, you're going to see more anastomoses procedures. All right, transplant surgery. Hey, remember with transplant procedures, there are three distinct components of work. You have the donor procedure, you have the back bench, and then you have the transplantation, right? One thing I love about CPT coding is that there's a lot of things that you see over and over and over again, and you're like, yeah, I remember that. All right, laparoscopy. So the first range of codes 44180, 44238. This is for surgical procedures only. Then there's a code for diagnostic. And so over in the surgical area, you see repairs, excisions, enterostomy. It's the same. How do I want to say? It's the same type of procedures, just tailored for that body part. And so when you see otomy, they're making an incision. When you see ostomy, they are doing some type of connection, right? Ostomy is artificial opening. When you're looking over at these codes, pay close attention to the body part, but also pay close attention to what they're doing with the body part, making sure that if it's an open procedure, your code reflects an open procedure. If it is an endoscopic procedure, making sure your code reflects an endoscopic procedure. So, speaking of endoscopy, we have small intestine endoscopy. One of the things you want to pay very, very close attention to in this area is the word stoma, stoma. A stoma is a surgical opening between a part of the intestine and the outside surface of the skin of the abdomen. And these particular procedures with the stoma means that when they put the scope in the body, they put the scope in via the stoma. So what you have to pay close attention to, was the scope inserted into a natural body part, or was it inserted into a stoma, an opening? And the documentation will tell you, you know, which one it was. You just have to pay attention to select the correct code. And something that really, I don't know, just comes to mind for me is the insurance company already knows that a patient has a stoma, and so if you do something, a different procedure in that same area, their computers might say, "Whoa, whoa, whoa! We thought this patient had such and such." So something just to consider. All right. Intestines, introduction and repair. Introduction of a long gastrointestinal tube is reported with code 44500. This particular GI procedure is not the same as the nasogastric tube placement. This particular procedure, 44500, is typically referred to as the Miller-Abbott procedure. This is where a mercury-filled balloon is swallowed that carries it into the small intestine. The patient is seated lower than the person performing the procedure. The balloon is then inflated slightly and pulled outward until the obstruction is encountered. They can do this procedure with and without a fluoroscopy. So that's what that is about. All right, repair codes and other procedures wrap up this subsection. And these procedures include closure of the large intestine. And what you're going to see here is really like four different things: suturing of the small intestine, closure of an enterostomy, closure of an intestinal fistula, or intestinal plication. I think that that word on the slide is spelled wrong. I didn't make these slides. I'm just delivering the content. But I should have caught that. Plication is Plication. All right, moving on to the appendix. And I'm sure you have heard about procedures on the appendix. The appendix is a small, twisted, tube like structure located at the blind end of the cecum. There's a diagram in the book that shows you the um, location of the appendix. Okay. So the appendix does not serve any known purpose in the digestive system. Coding for this area begins with incision and excision codes and then moves right on to um, laparoscopic. And there is an open laparoscopy code 44950. This is used if it's performed by itself, not in conjunction with any abdominal procedure. If they do something else, something other clinically indicated reason, you have code 44955. All right, on to the colon and the rectum. So the rectum is found at the end of the large intestine, the distal end. It helps us to remove waste from the body. And you have codes for all sorts of procedures, but the more common ones over here are the SCOPy procedures: proctosigmoidoscopy, sigmoidoscopy, and then colonoscopy. And the definitions of these procedures are basically going to vary based upon how far into the colon they are going. Okay, so you got to read the report to know what type of scope was used and what they did. All right, anus, the most distal structure in the digestive system. Remember medical terminology, you learn proximal and distal. So important here. So, hemorrhoid is a procedure that is performed. Hemorrhoid is an enlarged varicose vein in or near the anus. Understanding terminology and the types of complications of hemorrhoids is important. Hemorrhoid types can be internal, external, or combined or mixed. Internal hemorrhoids are located near the superior vein. External hemorrhoids, those are the ones that people probably feel the most, are found outside of the external sphincter, like you could touch it yourself. And then we have combined or mixed hemorrhoids, and they're found in both places and they're usually dilated. Other terms you need to know are terms such as prolapsed, thrombosed, strangulated, ulcerated. The textbook goes into the different definitions of those clinical conditions. On to the liver. So the liver filters red blood cells, stores essential vitamins, and contains enzymes that break down poisons in our body and produces bile that helps to break down the fat. And in case you are wondering, hey, is there a liver transplantation code? You betcha. And it includes the three components of distinct work. If you don't remember anything else, you'll remember the three components of transplantation procedures. So over here, you do have procedures for incision, excision, of course, the transplant, repairs, another scope, laparoscopy, and other procedures. All right, so on to the biliary tract, which is composed of organs and ducts that are involved in processing and the movement of bile into the duodenum. The organs and the ducts include the liver, the gallbladder, and the bile ducts. Knowing the approach that the surgeon used is very important to determine the correct code structure. And the range of codes include, what we've been seeing. Now, notice that they kind of use the word endoscopy, laparoscopy, right? And as always, look out for diagnostic or surgical, because you know the rule about that. There are some really cool pictures in the textbook that show you like a laparoscopic cholecystectomy, and they show you from different views. So it's really cool just to see what is happening. All right, on to the pancreas. The pancreas is located behind the stomach and is connected to the gallbladder and liver by way of the common bile duct. The pancreas secretes juices necessary for digestion, but also regulates blood sugar with secretion of the hormone insulin. So, in this particular area, you see codes for incisions, excisions, introduction, repairs. Yes, you see transplant and then other procedures. And guys, we are almost done. Abdomen, peritoneum, and omentum. So the abdomen is the area of the body that lies between the thorax and the pelvis. The peritoneum is the membranous lining of the abdomen. The omentum is part of the peritoneum that connects the stomach to other structures. So procedures that you will see over here: incision, excision, laparoscopy, diagnostic and surgical, hernia repair, other procedures, introduction, revision, and removal. So, as it relates to hernia surgery, so hernia is a protrusion or bulge through the tissue that normally contains a structure. Hernioplasty, herniorrhaphy, herniectomy are all terms used when referring to hernia repairs. And repairs are usually made with sutures, mesh, or wire. Unless otherwise stated, the codes in this particular area are unilateral. So if you do a bilateral procedure, you need to add a modifier 50. Um, it is very important that you understand the different types of hernia: inguinal, indirect inguinal, direct inguinal. So direct and indirect is a thing. Hiatal, incisional, strangulated, ventral. The textbook defines all of these. Um, what you really want to know is to code these procedures, right? Is it initial? Is it recurrent? The age of the patient, also the clinical presentation. Is it reducible, incarcerated, strangulated? Was it open versus laparoscopic? And whew, we talked all things digestive system. I will see you back with the urinary system.